So I have the challenge of being the first speaker after lunch. Not the easy slot, but I'll take it. So, today, first I want to thank Dr. Green for a very kind introduction, and thank Dr. Riley for kindly inviting me to this great symposium. I'm going to talk about the mobile health aspects of social and behavioral sciences. Before proceeding further, I would like to acknowledge that many of the work that I'm going to describe would not have been possible had it not been for generous funding from National Science Foundation, National Institutes of Health, and the BD2K initiative of NIH that funded the mobile sensor data to knowledge, the MD2K Center of Excellence. So just to start off, we live in the era of mobile devices, and they are all around us. Most of us are carrying mobile devices with us. They carry some sensors that can continuously collect data, some of which can be an indicative of risk factors. Others could measure outcomes. Or just call out a few examples. So GPS can measure geo-exposures. GPS can measure movements or transportation. Accelerometers embedded in the mobile phone itself can measure physical activity episodes. Then microphone embedded in the mobile phone, they could measure social interactions. So all of this could be measured passively throughout wherever we are. And then the newest device, the smartwatches, and they nicely complement the smartphones, and they include inertial sensors that can measure the arm movements that could indicate eating or smoking behaviors. They can also measure physiology, and from which we could derive a variety of different measurements, such as the stress. They can also measure the ambience surrounding us, such as the temperature or the sound levels. And then they could also be used to provide brief interventions. And so gradually, I think mobile phones have certainly become part of our habit that we take with us every day. Perhaps in the future, of the smartphones smartwatches could also become part of the habit. And if these are all part of our habit, then it behooves upon us to try and see in what ways we can use it to monitor and improve people's health. So I'll start off with one example, how we could increase precision in the temporal precision of precision medicine. So suppose we use the genomics data, proteomics data, microbiome analysis, all of this, and find that someone is at the risk of hypertension, then certainly the person could become more cautious, they could become cognizant, but still from the onset of a particular disease, that it's hard to determine unless we have the monitoring of the person at all times. So if in addition the person can be monitored with a mobile device, then we could determine any onset of the disease before irreparable damage occurs to the end organs like kidney or the heart. So mobile health basically, when combined with other technologies, can add the temporal precision in detecting or early detection of a disease. So in general, mobile devices could help, could provide three kinds of help. First, early detection of any disease. Second is if we can have early detection. So if it's a mobile technology that provides continuous measurement, so a benefit of measuring these outcomes or early detection of a particular disease condition is that we can have a continuous measure. So we can measure progression. If we can measure progression and then we measure other risk factors together with it, then what we have is we have progression of the disease and we have the measurement of the risk factors. So we can try to identify what risk factors at what level can lead to what worsening or improvement in the disease conditions or the symptoms. And if so, then we can use those risk factors that are also detected via sensors as predictors, and then we can indeed get into the era of preventive medicine that we can try to prevent with sensor-triggered intervention. Third capability that mobile devices introduce is that of adaptation. So if we can capture the outcome and adherence using mobile devices, then what we can also see is whether when we delivered certain intervention or the treatment, did it work, did it not work, did the person comply, did they like it? So, so these mobile devices indeed can offer us a way to personalize the medicine that we now envision as the future of medicine. Further, they can also see the current context of the user, whether the user is driving right now, that may not be the right moment to deliver an intervention. If the user is engaged in a conversation, that again may not be the right moment to deliver intervention. So not only the treatment can be adapted to or personalized to the person, but also to the context surrounding the person. So, so in the MD2K Center, in the MD2K Center of Excellence that was awarded last year, we have undertaken 2 applications for which we are trying to develop this just-in-time interventions that is triggered by sensors. So first is smoking cessation. For smoking cessation, there are lots of antecedents or precipitants that have been known from self-report analysis or from the laboratory measurements. Now we have an opportunity to look at sensor-based predictors. So to look at, say, stress measurements or to look at the visual exposure as measured by the smart eyeglasses. And and to find these novel sensor-based predictors. So for that, we first need to detect the occurrence of the event, and for that, again, sensors could be used to detect the timing of the smoking lapse. I'll talk a little bit more about each of these in the following slides. And then second example is the congestive heart failure. So smoking is the leading cause of preventable death. Then congestive heart failure is the leading cause of hospital readmissions. So for the congestive heart failure, again, what we lack is a non-invasive mobile device that could track the progression of the congestion in congestive heart failure patients. And so by using a novel sensor, we expect to have a method that can track the progression of congestion, and if so, then we could try to have an early detection before the person gets to the stage where they need to be rehospitalized. And so again, if we have that metric or that measurement that indicates the level of congestion, then we can look at other sensor data, such as, say, eating behavior or geo-exposures, and to see as to what kind of behaviors or what kind of risk factors worsen or improve congestion. And if so, then we can, in addition to having early detection, we can also have prevention in congestive heart failure patients. So there are a variety of sensors that we are using in MD2K. One is a chest belt that includes respiration and ECG sensors and accelerometry. Then the second sensor is the smart watch sensor that has inertial sensing in it. Third sensor is a smart eyeglass that can capture visual exposure. The fourth sensor is those that are embedded in the smartphone itself, the GPS and the accelerometer and self-report. And the fifth one, that's EasySense, which is a contactless sensor for measuring the physiology, much like an ultrasound that can measure both the movement within the body, so that means movement of the heart and the lungs, as well as the fluid level change in the lungs. So, so I'm going to take one example, and I'll take the example of a smoking cessation and stick with it for the rest of this talk, just to convey some points about where we stand today in terms of these developments and what challenges lie ahead of us. As I said at the title of the slide, my goal is to communicate the maturity level of these technologies, which indicates that there are tremendous research opportunities in this area. So, so in the smoking cessation, as I said, for risk factors, we now have GPS, which has been available for some time, and this can be used for monitoring the person, and I think several studies have started monitoring participants in a smoking cessation study with GPS data. So we can capture geo-exposure, such as proximity to tobacco point of sale, or proximity to bars, and a variety of other geo-exposures. We could also measure, say, a stress level from physiology on a continuous basis. We could also measure, say, social conflicts by using the microphone in from a mobile phone. So all of these are risk factors. The question is, so we have this continuous stream of data from a smoking cessation study. We recruited a bunch of participants. They wore all the sensors, and then they chose a quit date. They continued wearing the sensor before and after. So, so we have all these measurements, but how do we capture when is it that this first lapse occurred? So if we use the traditional method, which is self-report, then what we have is we have this continuous time series. We can tell when the participant was at a gas station. We can tell when the participant was driving. We can tell when the participant was at office. We can tell when the participant was out of the building or inside the building. We can tell when they were at home. We can tell when they were in social conflict. But if we depend on the self-report to pinpoint the timing of the lapse, then how accurate could we be? So, that's one of the questions that we sought to study. So I'll first mention the challenges. So here the goal is, can we develop a method to detect a smoking lapse from sensors? If we could, then we would have the precise timing of when the person lapsed at a minute or second granularity. Then we can go back in time and look at the precise place where they have been prior to the lapse, or their stress level, or their social conflicts, or any of the other sensor-derived risk factors that we have. And then we can try to find these predictors which can be used in delivering a sensor-triggered just-in-time mobile intervention, which could perhaps improve the abysmal rate of smoking cessation that we have today. But this is pretty challenging, and I'll try to describe some of the challenges which relates to the data science research challenges in developing any new measurement or any outcome or event detection from mobile sensor data. So first is the sensor itself. So development of sensor itself is not easy. The sensor that we develop should be wearable so that participants will wear it night and day rather than take it off as soon as they are out of our lab. It should be safe, that it should not cause them any problem. It should be reliable, that means we should be able to trust the data. It should be robust because the sensor is supposed to be worn during the entire day and while they are doing a variety of different activities. It should be versatile, that we shouldn't require the participant to wear one sensor for ECG, one sensor for tracking the arm movement, one sensor for eating, one sensor for activity, one sensor for physical, for transportation. So then, we are asking a person to walk with 10 or 100 sensor on them, and that's not feasible. So the sensor should be versatile. That means we are asking them to wear one or two sensors, and from them we need to derive as many possible set of measurements as we can. Then the other issues are that the software should be reliable enough, otherwise we'll lose the data. For making these sensors convenient, they're usually wireless, so a lot of data could be lost in the wireless channel. Battery should last long enough so that we shouldn't ask them to recharge every now and then. And then, if all of this somehow works, that means we are able to get data, we are able to get the participants to wear it, then what we get are basically just a bunch of bits and bytes, zeros and ones. That's all we get from the sensors. From that, we need to interpret what does it represent. So that means we need to convert that signals from the sensors into what was happening with the person. So suppose we are trying to detect a smoking from this wrist movement, okay? So that means we are trying to track when the person is taking the arm to their mouth and then taking a puff and then bringing it back. Now, the same thing could happen when we are eating. Same thing could happen when I've just brought my hand in here to scratch. Right? Same thing could happen when I'm yawning, right? So there are lots of different times when we engage in exactly similar kind of gesture. So which gesture represents the smoking, which gesture does not, right? Now, suppose we are trying to develop also this system or this inference to detect eating. So then, what are we trying to detect? We're trying to detect the person's taking a spoon and trying to eat, and then taking the spoon back. So then, sometimes we eat with a spoon, other times we eat a burger with one hand. Other time, we might eat a fruit with both hands, right? So there are lots of different ways that we engage in the same activity as a person. Now, different people engage in the same activity differently, right? And then there are so many other activities that they do which look very similar to what we're trying to detect. And since the people are wearing the sensor throughout the entire day, lots of different people are wearing the same sensor throughout the entire day, telling apart the activity that we're trying to detect from others is not easy. But it's something that excites data science researcher, and that's what makes for exciting research agenda for them. So, there are lots of, I'll talk about the team that we have at MD2K, fortunate to have a great team, and they enjoy tackling these kinds of challenges, and that's what they are working on. So I'm going to present some initial set of results for detecting smoking. So what we did was that there is lots of different confounders if we try to use just the gesture of taking the arm to the mouth. We combined this with breathing pattern data. That means when people do a smoking, they also take a deep breath, so deep inhalation and exhalation. So if we can synchronize the two and see the hand coming to the mouth, and then as the hand is leaving the mouth, then seeing a deep inhalation and exhalation in the breathing pattern, then if the two occur together, there is much greater chance that this represents a smoking and not something else. So we developed this method, and we trained this on a small set of data from 6 smokers. And then we applied this to a smoking cessation study that we are currently running, thanks to the OPNET initiative. And in this, we were able to obtain, I think, pretty good recall rate. So out of the 31 lapsers on which we had data, so we had 32 people lapse out of the 54 that we have run thus far. For one of them, there was high data loss, so we are left with 53. Out of this 53, there were 31 who lapsed. In this 31, we are able to pinpoint the timing of the first lapse in 27 of them. And then we ran this same model on those 22 who abstained for the 3 days that we were monitoring them. And when we apply the model on them, we get about 1/6, that means one false episode every 6 days. So I think the results thus far are encouraging, but I'll talk about the issues with this as well. Okay, so the good thing is that now we do have timing. So for those, that means on this 27 for whom we are able to detect accurately, we do have timing of when is it that they lapsed, and we can tell which breath is it when they took the first puff. Okay. So now we can look at all the other sensor data that point to the risk factors. So one question I had asked earlier in this talk was, how temporally inaccurate could self-report be? And we analyzed that because we had asked the participants to provide self-report too. So what you see here is on the top are those participants who did not self-report their first lapse. That's 9 of them. Then remaining 22 did report, and you can see the temporal inaccuracy in what they reported versus when we detect the first lapse. So in some cases, as you can see at the bottom, they reported before they lapsed. In other cases, when they report after the lapse, on average, the delay is about 43 minutes. So with this, if we depended on the self-report, then we would have said that, oh, the lapse occurred at the office, but it indeed occurred when they were at the gas station, and that we wouldn't have known. And another thing to observe is that the ones at the top, those who did not self-report, upon CO verification in the lab, then they were asked to recall when is it they think they would have lapsed. And the temporal inaccuracy for them is larger than those who self-report. So asking people to self-report in the field is better. So the results that I'm presenting here is done by my collaborators and the students and postdocs who are the ones who do the real work. So all the credit to them. So next, I wanted to also quickly present the cocaine use, but I think I'm running out of time. So I'll just quickly flash and say that we developed the same kind of method for cocaine use detection as well in collaboration with NIDA intramural research program. And in there, we were able to detect 27 episodes all accurately, and we could pinpoint the timing of that as well. Here also, we looked at the temporal inaccuracy of the self-report. So, I'll try to conclude. Do I have a few more minutes? So where do we stand? What I consider these results to be 0th generation. So if you think about other traditional measures we use today, they have been maturing for ages, right, for decades. And these are just fresh out of the oven. It will take them many years for them to reach the same level of maturity. And so they are not here to replace our traditional measures. They are here to complement. They are here to provide some information that we didn't have before. But it will take a lot for us to understand even what they represent. So first, validity. How do we validate? So this first lapse of smoking. So as I said, sometimes there is data loss, right? And participant provided self-report. So it's possible that the first lapse, when that occurred, the data for that is lost. And what we captured is not the first lapse, it perhaps is the second lapse. Sometimes we have false episodes. So it's possible that even on those who lapsed, the one we may have detected may be the false one. So what method do we use to validate the temporal precision we get with this new mobile-based measurements? That, to me, is an open question, because if we had such method already existing, we wouldn't need to develop this mobile-based method. So those gold standard don't exist to assess the temporal precision, but we need to do by with what we have. The second issue is limitations. What are their limitations? When can we use them? When can we not use them? What we developed is only with cigarette smoking. So this is not applicable to cigar smoking. This is not applicable to when there are several people who are sharing the same cigarette, right? Then usability. So we developed this method. At this point, my students are the ones who know how to write that code, and they can develop it. But if it's limited to them, then it's not usable. It's not used to the community. So the software should be such that it should be usable by anybody else in this room or anybody else around who is interested in this problem. It should work not just with one sensor or the Microsoft Band or the Apple Watch. It should work with a variety of different sensors that are out there. And then, this will just remain entertaining unless we show clinical utility of it. So when there is an intervention that is developed that makes use of this, that's when we'll find this to be scientifically useful. And developing those interventions, just-in-time interventions that are sensor-triggered, that's entirely a novel field as far as I can tell. So there's tremendous opportunities for all of us to dig in. So as I said, in MD2K, we are developing all this software that we plan to release publicly. And the MD2 team consists of 12 different universities, an amazing team. Bonnie Spring is one of the leads in MD2K who is going to present next. So we have amazing people in both computing and health research that form part of this team. For more info, if you're interested, I can log on to the MD2K. Thank you for your attention.